Hello, my name is Dr. Payal Kohli, and I'm a cardiologist who specializes in non-invasive and preventive cardiology. I graduated from Harvard Medical School, and I currently own and run a general cardiology practice in Denver, Colorado. In this video series, we're tackling 5 common misconceptions around the use of coronary CT angiogram, or CCTA, in the diagnosis of coronary artery disease. And we'll be debunking some myths. And this is the 5th video in our series. A common misconception that I hear from my colleagues that we'll be discussing today is that coronary CTA is not as safe for my patients as a stress test because of the excess radiation. So let's dig right into this one. What is the radiation dose for a coronary CTA, and how does that compare to, let's say, a calcium score, a SPECT, or even an invasive cath? Well, the Scott Hart trial had a sub-analysis performed that examined the first imaging test for almost 3,000 patients, where it was found that SPECT had the highest radiation dose for our patients. A coronary CTA was about 4.1 millisieverts in this study, and this was between 2010 and 2014. And this even included the coronary calcium portion of the test. So as you can see, a CCTA has much lower radiation dose than SPECT for our patients. Radiation exposure from coronary CTA has really fallen dramatically over the recent years. And the results of the Protection 6 trial, which examined the radiation dose of CT compared to a worldwide survey of SPECT, showed that there was a large reduction in the median dose of radiation with the CTs. The cardiac CT average was about 5.1 millisieverts across the 61 imaging centers worldwide. Now, compare this to the median radiation dose of 10.4 millisieverts, which was found in the INCAPS registry, and 14.9 millisieverts from the IAC repository for SPECT and PET tests. Again, you'll see that CCTA seems to be performing better in terms of lower radiation to our patients. And a big part of the improvement in coronary CTA reduction at radiation dose is due to better scanner technologies, better protocols, better training of the CT staff. So in my practice, I like to send my patients to facilities that have implemented many of these best tactics to try to reduce that radiation exposure to my patients. And what that means is sending them to better scanners, having higher resolution, and these are all ways to reduce the radiation dose that they have when they have trained CT techs doing a good, efficient job. So if you're worried about the radiation dose to your patients, I would highly encourage you to call up that imaging center, talk to the technician, talk to the radiologist. In fact, I had to do this myself the other day for a patient who was really concerned about radiation. And thankfully, they were able to assure her that the protocol that they were using was optimized to reduce her radiation exposure. Let's also consider how often an inconclusive SPECT may lead to more testing or repeated testing. Now you're talking about layering further radiation exposure for the patient. And an inconclusive SPECT may occur more often in women due to their breast tissue, which can create that attenuation artifact or that false positive anterior defect. We also know that obese patients can have higher incidence of non-diagnostic SPECT tests because of that diaphragm. And when we think about our younger patients, we really want to limit their lifelong radiation exposure by minimizing repeated testing or higher radiation nuclear stress tests. Lastly, let's not forget about the inconvenience and potential worry of having our patient go through multiple tests when layered testing occurs. The patient has to take more time off of work, they have to pay more copays, and at the end they don't get an answer and end up having to worry about their heart health a lot longer. So we want to be sure that we're doing the best test, and we're doing it in a calculated and thoughtful fashion so that we can really minimize our patients' chances of having false positives, false negatives, artifacts, or having to do repeat testing. So let's summarize. Our misconception was that coronary CTA was not as safe as stress tests for our patients because of that excess radiation exposure. I've showed you some studies that have demonstrated lower radiation with those coronary CTAs versus those SPECTs, and the CCTA technology and protocols are really getting better every day. So let's try to focus on our patients. They want an accurate test, they want an answer the first time, and they want to minimize their radiation exposure. With coronary CTA, we can often get a really complete picture of our patient's heart health. This concludes the series of videos about the misconceptions around the use of coronary CT angiogram in the diagnosis and management of coronary artery disease. Thank you so much for tuning in. I hope that you walk away today with a better understanding of coronary CTA and really what a valuable tool it is in your clinical practice.